Hello, everyone, and thank you for joining this month's Bench to Bedside webinar series. I'm Nicole Wilson, Program Manager for the United Mitochondrial Disease Foundation. We're so glad you're here. Before we get started, I would like to remind everybody about MitoShare, our worldwide patient-populated registry. This is the ideal place to help capture the overall journey that our patients experience. So please let your patients know about this important registry today. Save the date for MitoMed 2025 in St. Louis, Missouri, June 18th to the 21st. You can learn more at umdfconference.org. We hope we get to see you there.
Hi, everybody. Welcome to the first Bench to Bedside of 2025. I'm really excited to have you join us today. We have a great lineup of speakers, and I'm Mel. I think it's really exciting to see that we now have so much clinical trial activity taking place inside mitochondrial disease that we have to actually spread this over two Bench to Bedsides.
Agreed. Very exciting and happy 2025, everyone. We are so glad that we have our second part of a clinical trial update today that focuses on mitochondrial DNA disorders, and more specifically, the most common mitochondrial DNA mutation, the M3243A to G. And to kick off our presentations today is Dr. Ingrid Tein. She is the director of the Neurometabolic Clinic and Research Laboratory at the Hospital of Sick Children in Toronto. She is also there to serve as a staff neurologist in the Division of Neurology. Dr. Tein, in addition, holds an academic appointment as an associate professor in pediatrics, laboratory medicine, and pathobiology, and as a senior associate scientist in the genetics and genome biology program at the Sick Research Institute. And so we're very glad to have her here today to tell us more about 3243 disease and potential treatments. Dr. Tein, welcome.
Thank you for that kind introduction. I'm just going to share my screen now. Can you see it?
It's still coming up. And while your slides are loading, I just want to remind everyone that we're using the Q&A function today for questions. We'll do our best to get to as many of them as possible, but we may not have time. And our speakers have offered to follow up on anything that's not able to be addressed here in the seminar. So again, any questions for the speakers, use the Q&A function, please. All right, Dr. Tein, turn it over to you.
Okay, and can you see my screen now?
Yes.
Okay, and can you hear me clearly?
All
Yes,
set.
we can.
Okay. Thank you very much for this kind invitation to speak at the UMDF Bench to Bedside series. My disclosures relate to the grants that have funded our work over the years, and the work that I'll be presenting was funded by the United Mitochondrial Disease Foundation, for which we're very grateful. The goals of my talk are to present our data on the role of L-arginine in MELAS syndrome on cerebrovascular reactivity, cerebral blood flow, neurovascular coupling. Time permitting, I would also like to present our complementary data on the effects of L-arginine on total aerobic capacity and muscle aerobic metabolism, because it dovetails very nicely with the cerebral data. Now, as you all know, the mitochondrial respiratory chain is the final common pathway of oxidative metabolism, where complexes 1, 3, 4, and 5 have both nuclear and mitochondrial DNA encoded subunits. And each cell contains many copies of mitochondrial DNA, and during mitotic segregation, the ratio of mutant to wild type will determine the clinical phenotype, with higher morbidity associated with higher percentage mutant heteroplasmy. The most common mitochondrial DNA inherited disorder, as you've heard, is MELAS syndrome due to the M3243A to G point mutation in the transfer RNA leucine in the MTTL1 gene, which leads to dysfunctional assembly of mitochondrial DNA-encoded respiratory chain complexes, and particularly complex 1. The clinical phenotype is one of recurrent stroke-like episodes and migraine headaches, focal or generalized seizures, cortical blindness or hemianopsia, hemiparesis, intellectual disability, sensorineural hearing loss, short stature, failure to thrive, lactic acidosis, as well as the possibility of multi-organ dysfunction. The stroke-like episodes are unique in not being restricted to large vessel distributions and have a predilection for the occipital, parietal, and temporal lobes, and can spread subacutely over hours to days to weeks, but may have a greater potential for reversibility than classic vaso-occlusive strokes. This serial DWI imaging shows the spreading metabolic stroke from the left temporal to the occipital to the parietal cortices. Now, the proposed mechanisms for the pathophysiology of the stroke-like episodes have included a mitochondrial small vessel angiopathy based on the observed mitochondrial accumulations in endothelial and smooth muscle cells, and or a primary mitochondrial-mediated cytopathy involving neuronal and glial injury, and is likely a combination of both. The predilection for the parieto-occipital regions may be related to the cortical spreading depression, which begins in the occipital regions and may be associated with the triggering migraine headaches. Now, our story begins with a boy who presented at 8 years of age with right temporal lobe swelling and left hemiparesis, which recovered almost fully. At 10 years, with infection, he developed headache, vomiting, and a dense right-sided hemiplegia with right-sided focal seizures, right superior quadransenopia, and aphasia, and had high flare in the left temporal parietal lobe with edema, and elevated MRS and serum lactates. His acute deficit remained entirely unchanged for 5 days. Genetic testing confirmed the MELAS mutation, and he was treated with high-dose intravenous L-arginine, and within 24 hours showed rapid improvement in his right hemiplegia and aphasia. He was then switched to oral L-arginine, and with vomiting, he had a recrudescence of his hemiplegia and aphasia. He was again treated with intravenous L-arginine and had rapid recovery of his deficits, and then his L-arginine was more slowly tapered to maintenance. At 3 months, he had no weakness or field cut, and his speech was improving significantly. At 13 years of age, again with infection and vomiting, he developed headache with diplopia and a right sixth nerve palsy. His MRI showed new abnormal signal in the bilateral basal ganglia, right occipital pole, and in the right pons. He received high-dose intravenous L-arginine, and within 24 hours had complete resolution of symptoms. And his repeat MRI 3 days later showed resolution of the pontine lesion. We thus became very interested in understanding the potential mechanisms further. Now, L-arginine and its metabolites have multiple physiologic roles, including its conversion to nitric oxide, leading to endothelial relaxation, to ornithine for ammonia detoxification, to creatine, which is a bioenergetic substrate in brain, and to agmatine, which is involved in cell signaling and neurotransmission. Intriguingly, it can be converted by several steps to alpha-ketoglutarate, which is a Krebs cycle intermediate, which could improve cellular anaplerosis and thereby cellular energy homeostasis. With these questions in mind, we designed a study to probe the pathophysiology of the stroke-like episodes and the mechanisms of action of L-arginine in MELAS by quantifying its effects on cerebrovascular reactivity to CO2 stimulus using bold MRI on a 3 Tesla MRI, to cerebral blood flow by arterial spin labeling, on neuronal cell activation of cerebrovascular reactivity by bold fMRI, and on muscle oxidative function by 31-phosphorus MR spectroscopy, and on total aerobic capacity by maximal graded cycle ergometry in a cohort of siblings with the 32438G point mutation. So our 3 MELAS SIBs had variable percentages of mutant mitochondrial DNA in blood, ranging from 35% in MELAS 1, who had no clinical phenotype and excellent cognitive function, 41% in MELAS 2, who had sensory neural hearing loss, neuropathy, exercise intolerance, and minimal cerebral atrophy and microcephaly, and 59% in MELAS 3, with sensory neural hearing loss, right hemianopsia, and left greater than right parieto-occipital stroke-like episodes with gliosis and atrophy of the left greater than right occipital lobes and a low MoCA score. These SIBs were compared to 4 age and sex-matched healthy controls, and our key neurology resident, Lance Roden, was involved in this study. Now, baseline investigations were done in the MELAS cohort compared to the healthy controls. The response to L-arginine was assessed only in the MELAS cohort to a single dose of oral L-arginine, followed by 6 weeks of steady-state oral L-arginine, and compared to their baseline performance. Now, baseline serum arginine levels were significantly lower in our MELAS patients compared to the healthy controls. The etiology is unknown. However, we propose that chronic cerebral hyperperfusion between stroke-like episodes requires increased production of nitric oxide, which could secondarily deplete the arginine stores, and that a significant metabolic stressor, such as infection, would further increase cerebral hyperperfusion, causing arginine levels to plummet further, as is seen in the stroke-like episodes. Now, our serum arginine levels increased significantly in all 3 MELAS SIBs to single dose in yellow and to 6-week steady state of L-arginine, as shown on this graph. Now, in our first study, we measured regional cerebral blood flow on a 3 Tesla MRI using arterial spin labeling, and we measured arterial cerebrovascular reactivity as a change in the percentage blood oxygen level dependent, or BOLD signal, as a surrogate of cerebral blood flow to 4 60-second intervals of hypercapnic challenges in which the CO2 was raised 10 millimeters of mercury above baseline using our unique rebreathing circuit with the guidance of our neuroradiologist, David MELAS. So in other words, the CVR is the percentage change in blood flow per unit change in flow stimulus in millimeters of mercury. The unique rebreathing circuit is a sequential gas delivery breathing circuit which precisely controls PET CO2 and PET O2 independent of the subject's ventilation, and was invented by our study collaborator and anesthesiologist Joe Fisher. So here, to summarize the enormous amount of data, on the left is the voxel by voxel CVR-Z maps that are standardized to 19 normative healthy adult controls ages 20 to 30 years and superimposed on neuroanatomical scans. The color scale varies from very low reactivity, as indicated by the purple color, to high reactivity, as indicated by the dark green color. You will note that the 3 MELAS SIBs had markedly decreased CVR, which progressively decreased with increasing percentage of mutant heteroplasmy compared to the CVR in our controls. Now, on the right, quantitative cerebral blood flow was measured by arterial spin labeling and compared again to a cerebral blood flow atlas of 14 healthy controls and compared voxel by voxel. And here the color scale varies from blue-green with normal blood flow to red indicating hyperperfusion. You will note that the MELAS SIBs had increasing hyperperfusion with increasing percentage of mutant mitochondrial DNA, which increased in the frontal lobes. And in MELAS 3, the occipital regions show lower flows because these are infarcted tissues. Now, on analysis of the regions of interest, aided by our biophysicist Julien Poublanc, our MELAS SIBs had a significant decrease in cerebrovascular reactivity and increased cerebral blood flow, which was statistically significant compared to healthy controls. The changes correlated with disease severity and percentage mutant mitochondrial DNA and were inversely proportional for CVR in the frontal and occipital cortices and directly proportional to cerebral blood flow in the frontal regions, but not for the occipital infarct penumbra as expected. Of note, the mean CVR was reduced more in the frontal versus the occipital cortices, and the mean cerebral blood flow was increased more in the occipital than frontal cortices compared to controls. And as expected, cerebral blood flow correlated inversely with the cerebrovascular reactivity in the frontal regions, suggesting that the increased frontal resting flow is at the expense of flow reserve. We speculated that the demonstrated cerebral hyperperfusion may be the result of a normal flow control mechanism responding adaptively in an attempt to compensate for metabolic imbalance resulting from the inefficient utilization of oxygen for ATP generation by abnormal non-vascular cerebral mitochondria. And we speculated that the cerebral blood flow may serve as a safe and non-invasive prognostic marker to stratify the risk for future stroke-like episodes in our patients. We then studied the effect of single dose and 6 weeks of L-arginine on cerebrovascular reactivity, cerebral blood flow, and on neurovascular coupling compared to baseline in our 3 MELAS sieves. Now, again, to summarize an enormous amount of imaging data, I will just give you the conclusions and the results. We noted a trend toward increasing CVR in the frontal cortex and a corresponding decrease in CVR in the occipital cortex on L-arginine therapy compared to baseline in our symptomatic MELAS siblings 2 and 3. Asymptomatic MELAS 1 demonstrated no major change. In addition, there was dramatic 30% reduction in baseline cerebral blood flow in the frontal and a 37% reduction in the occipital cortex in MELAS 2 following the 6 weeks of L-arginine therapy. We speculated that L-arginine appears to selectively increase cerebrovascular reactivity in regions most impaired at the expense of less abnormal regions, and that it appeared to ameliorate the hyperperfusion, which may have been due to improved neuronal energy metabolism and/or a normalization of vascular tone. Now, in this study of cerebral blood flow in MELAS 1 and MELAS 2 at baseline and post 6 weeks L-arginine, you can appreciate that MELAS 2 has marked hyperperfusion at baseline, particularly in the occipital regions, which is markedly reduced towards more normal flow following the 6 weeks of L-arginine therapy. In our third set of experiments, we were interested in neurovascular coupling, whereby a neuronal stimulus triggers a hemodynamic response, which can then be detected on bold fMRI activation. Our neuronal stimulus was an alternating black and white checkerboard pattern at 8 Hz, which was projected through our MRI goggle system. The percentage bold signal change was measured in the primary visual cortex V1 in Brodmann area 17 and in the extrastriate regions of the secondary visual cortices V2 to V5. So again, summarizing an enormous amount of data, the percentage bold signal varies from relative hypo or inactivation in blue to marked activation in the orange and red colors. Now, you can appreciate in these 4 controls and in MELAS 1, even before L-arginine, that there is marked activation of the occipital cortices in the 4 healthy controls and MELAS 1. In contrast, the bold fMRI in MELAS 2 was significantly reduced in the striate and extrastriate areas of the visual cortices in symptomatic MELAS 2 and was markedly increased towards normal following a single dose and 6-week steady state trial of L-arginine therapy. On quantitative analysis of MELAS 2, following L-arginine, there was a restoration of fMRI signal by 2 to 2.75-fold toward low healthy control values. So on review of the data in the aggregate, L-arginine normalizes resting blood flow from elevated pretreatment levels. It selectively increases cerebrovascular reactivity from reduced pretreatment levels in regions most impaired at the expense of less abnormal regions. And it markedly increased the reduced bold fMRI activation in response to visual cortical stimulus in our affected patient. We propose that the healing effect may be secondary to more efficient utilization of energy substrates, which is why we're very interested in the conversion of arginine to alpha-ketoglutarate for cellular anaplerosis, leading to increased cellular energy balances, and that there is an ensuing reduction in the activity of the signaling pathways that augment flow in the untreated state. So we were also interested in the effect of L-arginine on total aerobic capacity and muscle metabolism. From the elegant work of Taivasalo and Haller, maximal graded cycle ergometry has proven to be a highly useful diagnostic tool in mitochondrial myopathies. The patterns noted relate to the inability of affected muscle to extract oxygen for oxidative phosphorylation and the marked physiologic responses of the body to increase blood flow to deliver more oxygen to the exercising muscle. And as you can see from their studies, there is a marked increase in cardiac output and ventilation, which is greater than normal and out of keeping to the amount of oxygen uptake that occurs. And the oxygen extraction per unit of blood is severely attenuated, which leads to a mean peak work capacity decrease. And the most sensitive parameter here is the mean oxygen uptake, which is significantly lower and which is inversely proportional to the percent mutant heteroplasmy. Now I will again summarize a large amount of data. So on maximal graded cycle ergometry, following L-arginine therapy, the MELAS SIBs were noted to have an increase in their mean percentage of maximum work and maximum heart rate at the anaerobic threshold, with a small increase in peak oxygen extraction, signifying some improvement in aerobic metabolism. To examine the specific effect on muscle metabolism, we used our MR-compatible up-down cycle ergometer in our 31-phosphorus MR spectroscopy system with the expertise of our postdoc, Greg Wells. So the patient lies down in the magnet and pedals this up-down cycle ergometer that's MR-compatible, and spectral measurements are taken through the quadriceps muscle. So these are typical spectra. At rest, you can appreciate the high phosphocreatine peak, the inorganic phosphate peak, and the 3-ATP peaks. Following exercise, there is a decrease in phosphocreatine and an increase in inorganic phosphate as ATP is converted to ADP. And the time for recovery of this phosphocreatine peak is a highly sensitive measure of mitochondrial function. So the longer it takes to recover, the higher the percent mutant heteroplasmy in muscle. We run 3 exercise protocols. The first measures high energy phosphagens at a 30-second bout at 100% maximal work. The second measures primarily anaerobic exercise at 85% of maximal work. And the third measures primarily aerobic exercise, bouts of 30 seconds of exercise at 65% of maximal work, separated by 15-second rests. So at baseline, the 3 MELAS SIBs compared to healthy controls had statistically significant increases in phosphocreatine in muscle, decreased ATP reserves, and very interestingly, markedly decreased intracellular magnesium, which is vital for energy transduction and for muscle contraction and relaxation by competing with calcium. And the following mean trends, again summarizing a great deal of data, were noted in the MELAS SIBs following the L-arginine therapy compared to their baseline. We noted a blunted decrease in pH after exercise, signifying less acidosis. There was an increase in the inorganic phosphate to phosphocreatine ratio, which is a surrogate for ADP, suggesting increased work capacity. And in MELAS 2, who had the most significant exercise intolerance, there was a faster half time of phosphocreatine recovery following aerobic exercise, which went from 100 seconds to 40 seconds, which was within normal limits. And we also noted an increase in torque, suggesting increased power. We thereby concluded that with L-arginine therapy, there was an improvement in overall aerobic capacity and an improvement in muscle metabolic aerobic function. And we speculated that the marked intramyocellular hypomagnesemia may prove to be an interesting therapeutic target in the future. It's actually been shown in patients with MELAS and patients with migraine that they have lower cerebral magnesium also. Now, taking this basic data to the bedside again, we published in the Neurohospitalist Journal a multidisciplinary protocol for the meticulous perioperative management of renal transplantation in our very complex MELAS proband, who I've previously described, who had not only recurrent stroke-like episodes, ptosis, optic atrophy, sensory neural hearing loss, myopathy, exercise intolerance, sensory motor axonopathy, but also hypertrophic cardiomyopathy with hypertension, and at age 16, renal failure. And we were able to, with our multidisciplinary team of cardiologists, metabolists, neurologists, intensivists, develop a protocol for the meticulous preoperative, intra, and postoperative management of our proband. And we were able to maintain meticulously his L-arginine levels in the serum between 100 to 150 micromoles per liter, and he suffered no stroke-like episodes or seizures, and remained seizure-free as well as stroke-like episode-free for the ensuing 2 years. And so I think at this point, I would just like to say that our, as for all complex multisystemic diseases, it takes a village to meet the multifactorial needs of the child and their family. And I've just been blessed to be part of a highly talented and dedicated team of subspecialty clinicians, an on-site mitochondrial laboratory led by the late Brian Robinson, as well as exercise physiologists, metabolic dietitians, our excellent neurometabolic nurse, Lynn McMillan, genetic counselors, and parent support group to serve the needs of these highly complex children. I thank you for your attention.
Thank you very much, Ingrid. That was fascinating. We only have one question, and it's about oral citrulline and whether it's equivalent to L-arginine. I don't know if you are able to answer that. Otherwise, Fernando.
Yes, and as a matter of fact, citrulline is much better tolerated than L-arginine. L-arginine is extremely nausogenic, and that can be a major problem for patients to tolerate. And we've actually substituted equimolar amounts of citrulline and found that we've been able to attain better serum arginine levels because its metabolism is different from the metabolism of arginine. So it actually works, I think, very effectively, and it is also much better tolerated. It doesn't have the nausogenic nausogenic potential of L-arginine. So our patient is actually now on citrulline chronically. But in the acute situation, when one needs a high dose of arginine, then he receives the intravenous L-arginine, and then we titrate the doses as he's coming out of the intercurrent issue.
I'm just going to wrap up with a reminder that Bench to Bedside is a monthly series, and in February we have a focus on the role of rehabilitation medicine in the care of children with mitochondrial disease. Several speakers you see listed on the screen will be joining us. So that's Monday, February 10th, 2025 at 12 p.m. Eastern Time. With that, we're going to wrap up today's Bench to Bedside. Thank you for your attendance and look forward to seeing you at